Hello, everyone. My name is Tyler Sullivan, and I am a fourth-year medical student at Toro University, California. Welcome back to our four-part video lecture series on stroke syndromes. In the last video, part 2, we covered the anterior circulation strokes, specifically the proximal M1 segment stroke of the MCA. Here in part 3, we will finish the anterior circulation strokes, covering the middle cerebral artery superior division and inferior division, as well as the lenticulostriate artery strokes and strokes of the anterior cerebral artery. So, part 3. The superior division of the MCA supplies the lateral frontal and superior parietal lobes. This is one of the most common locations for an embolic stroke, either from a proximal arterial source like the carotid artery or directly from the heart. Infarctions typically result in a contralateral hemiparesis and hemianesthesia, affecting the lower face and upper extremity, not affecting the leg because, again, this is the ACA territory. It'll also result in a gaze preference to the ipsilateral side of the lesion due to frontal eye field involvement, like we saw in the proximal MCA stroke. With an infarct in the dominant hemisphere, there is often an associated Broca's expressive aphasia. Now we move on to the inferior division of the MCA, which predominantly supplies the lateral temporal and inferior parietal lobes. Inferior division territory infarcts do not cause weakness or sensory loss. They are typically associated with either contralateral homonymous hemianopia or contralateral homonymous inferior quadratinopia. If in the dominant hemisphere, the patient may have Wernicke's receptive aphasia. If in the non-dominant hemisphere, the patient may have contralateral hemi-neglect or an acute confusional state. The lenticulostriate arteries are branches of the M1 segment of the MCA that ascend to supply the caudate nucleus, putamen, globus pallidus, and internal capsule. The infarcts here tend to be lacunar, which is said to be due to hyaline arteriosclerosis caused by unmanaged hypertension. Some have suggested that they are more often due to an embolism of cardiac origin. Nevertheless, lacunar syndromes most commonly affect the elderly with long-standing hypertension, and they are characterized by a lack of cortical signs such as hemi-neglect, aphasia, and hemianopsias. There are over 20 lacunar syndromes that have been described, but the most common clinical presentation of lenticulostriate artery lacunar infarcts is one of pure motor involvement, and this is due to involvement of the posterior limb of the internal capsule. So moving on to the remainder of the anterior circulation strokes, we're going to go over another case. So a 75-year-old male presents with acute loss of the ability to move his left hip and leg. On exam, he has decreased sensation to pinprick and vibration of his left leg, and his CT scan is shown on the right here. Which artery is involved? So the anterior cerebral artery, or ACA for short, is the correct answer. This is also part of the brain's anterior circulation, and it supplies the medial, frontal, and parietal lobes, which are shown in the green vessels here. An ACA stroke is much less common than an MCA stroke, accounting for approximately 3% of all acute cerebral infarcts. If a stroke occurs in the ACA prior to the anterior communicating artery, here, for example, it is usually well tolerated because of collateral circulation that allows for blood to cross over the anterior communicating artery from the other side and supply the rest of the ACA's territory. Of note, the anterior cerebral artery anterior communicating artery junction is a common site for aneurysms. The bottom right imaging shows a pericallosal artery aneurysm, which could lead to a hemorrhagic stroke. However, we're going to stick to the ischemic strokes for this lecture. Similar to the MCA stroke, an ACA stroke will result in contralateral hemiplegia and hemianesthesia, except the lower extremity will be more affected than the upper extremity, and the face will not be affected at all. This can be explained by the ACA's territory on the homunculus, which predominantly includes the lower extremity. ACA infarcts may also affect the nerves supplying the pelvic floor muscles, which could lead to urinary incontinence. Another unique feature of the ACA syndrome has to do with its prefrontal cortex involvement, which historically has been connected to some of the most distinctly human intellectual traits, such as judgment, foresight, motivation, memory, a sense of purpose, and a sense of social propriety. Therefore, a lesion to the prefrontal cortex may result in abulia, which is a lack of initiative or motivation. It could lead to disinhibition or impulsivity, described as a lack of social restraints or the inability to control their behavior. Impaired memory or reemergence of primitive reflexes such as sucking and grasping. And so that's it for anterior circulation strokes. Here are my references for parts 1 through 4. The next video is the last one of our 4-part series, and in it, we'll be covering posterior circulation strokes.